Hi, I'm Dr. Janet Pope, a reporter at Room Now. My Twitter handle is at Janet Bordeaux. I'm reporting on rheumatic diseases that really can take your breath away. So I'm going to start with some scleroderma information. So abstract 1846 by Dinesh Khanna et al. Looked at the nintedanib study, RCT, in active pulmonary fibrosis or interstitial lung disease that was a fibrotic type phenotype in systemic sclerosis where patients were randomized to nintedanib or placebo. So that's data from the census trial. And overall, not surprisingly, and fortunately for our patients, it was a positive study showing less worsening with patients on nintedanib than on placebo, of whom in each group about half were on background mycophenolate mofetil. They've already presented, members of the census group have presented that mycophenolate mofetil plus nintedanib seem to give the least amount of worsening, so slowing worsening of FVC. Then it was either nintedanib or mycophenolate mofetil. And then if you were on placebo and no mycophenolate mofetil, you had the most worsening. So today, what they wanted to ask was the factors of rapidly progressive interstitial lung disease. If you looked in the scleroderma patients in the census trial, did they make a difference on nintedanib being more protective? And the easy answer is yes, they did. But these are the factors. Early diffuse systemic sclerosis would have more decline in FVC, so it was more protected with nintedanib. High inflammatory markers like CRP or probably ESR, again, high inflammatory markers, more protective if you were on nintedanib than placebo. A high modified Rodnan skin score, that wasn't so high. They cut it off at about 18, but you have to realize about a third of the patients in the study were limited cutaneous systemic sclerosis, and they would have a really low skin score. So all these things fared better individually if you were on nintedanib than placebo. Then they did something really smart, and they combined the data and showed that nintedanib with all these groups combined, the highest risk groups, it was still more protective on nintedanib than placebo. So I think really just showing the consistency of the data. The other thing for healthcare utilization, which is important, there was an abstract number 1839. It was a poster, and it was a US cohort of scleroderma patients, the Genesis cohort. And it looked at morbidity, and in this case, mortality of by ethnic lines. So white, Black, Asian. And Asians had the medium amount, white, Black, Hispanic. And Hispanic patients had medium mortality. So Black, the worst. And the Hispanics, interestingly, were younger, had more RNP, and had more lupus overlap. Right now, we're not sure, though, who had more ILD and what the cause of death was in these patients. So more will come on that. Then there was a really nice oral presentation that I think needs a shout out. And that was looking at RA, ILD, and survival. And this was presented by a trainee, and she did a great job. And I thought it was one of ACR best. So it was abstract number 1918. It was presented today at the ACR 21 Convergence. And I thought it was the smoking gun because she followed patients from the VA. So we know VA has more men and higher rates of smoking than general population of RA patients. So they had RA, they were mostly smokers, and they had far more males than females because of where the data were gathered from. And there were two things that the questions were to ask. What about mortality with RA if you had ILD and high disease activity or moderate rheumatoid disease activity? And what about damage as measured by the MD HAQ, so the Health Assessment Questionnaire of Functional Impairment? And both damage and disease activity of RA, so of their joints, both independently predicted lack of survival, so increased mortality, and those with RA ILD. So the take home is that certainly RA can make you breathless, but RA disease activity will kill you more so. We have shown with one of my trainees and published this year in A&R that high self-reported disability, so a high HAQ score or high functional impairment in early rheumatoid arthritis did reduce survival over the long term. So I think all this sort of factors in that no matter what, whether it's your lungs or not with your RA, you've got to treat the underlying disease in the RA, the inflammatory arthritis. So please follow us at Room Now. I think you'll find that there is a huge plethora of data on ACR 2021. Thank you.